This session covers pharmacist scope of practice. We'll dive into collaborative practice agreements, direct prescribing authority across several states, and how some other large countries utilize their pharmacists for primary care. A collaborative practice agreement, or a CPA, is a legal document in the United States that establishes a legal relationship between clinical pharmacists and collaborating physicians or other providers that allow for expanded services the pharmacist can provide to patients and the healthcare team. CPAs can define certain patient care functions that a pharmacist can autonomously provide under specific situations and conditions. CPAs can be specific to a patient population, specific clinical situation or disease state, or they may outline an evidence-based protocol for managing the drug regimen of the patients under the CPA. CPAs have been used in creative ways to improve care of communities in need. One recent example was giving barbers the opportunity to screen their customers for hypertension and then referring them to a pharmacist working under a CPA. Currently, 18 states have a CPA authority broad enough to allow pharmacists to prescribe pursuant to rapid diagnostic tests. Based on research from the National Alliance of State Pharmacy Associations, or NASPA, these states are Florida, Idaho, Illinois, Kentucky, Michigan, Minnesota, Montana, Nebraska, New Mexico, North Dakota, South Dakota, Tennessee, Texas, Utah, Vermont, Washington, Wisconsin, and Wyoming. New Mexico was the first state to allow pharmacists to prescribe. It passed legislation in 1993 to prevent an expected primary care provider shortage. It looks like it didn't really work, but at least they tried. Pharmacists who obtain pharmacist clinician certification can provide primary care and specialty care, which allows them to prescribe medications, including controlled substances, for chronic and non-chronic conditions. Organ pharmacists can prescribe drugs that are on a state-authorized formulary. The formulary includes a list of drugs, devices, and supplies, including diabetes testing supplies, nebulizers, INR testing, and ostomy products. They can also prescribe Sudafed, tobacco cessation, and nicotine replacement products, PEP, and travel medicines like vaccines. Idaho pharmacists are allowed to independently prescribe more than 20 categories of medications. And you can see a list of the categories here, from UTIs to diabetes testing supplies to medications that close gaps in care like statins. Florida pharmacists can initiate, modify, or discontinue drug therapy for any of the conditions on the top right of the slide, as well as any other chronic conditions adopted and ruled by the Florida Board of Pharmacy with the Board of Medicine and Board of Osteopathic Medicine. They can also test, screen for, and treat under written protocol with a supervising physician for the conditions in the bottom right of that slide. California pharmacists are recognized as healthcare providers who have the authority to deliver several healthcare services. Pharmacists with an advanced practice pharmacy license can initiate, adjust, and discontinue drug therapy, order and interpret drug-related tests, evaluate and manage diseases in collaboration with other healthcare providers, and refer patients to other healthcare providers. In North Carolina, pharmacists that become a clinical pharmacist practitioner, CPP, have prescribing authority, including the ability to prescribe controlled substances under supervision of a licensed physician. Montana has the exact same certification and authority. New York pharmacists that set up a collaborative drug therapy management arrangement with a physician to adjust or manage a drug regimen for a specific disease or disease state are limited to certain locations like diagnostic centers or treatment centers or hospital outpatient departments. Massachusetts pharmacists have a similar arrangement as New York, except they can practice in many more locations like retail pharmacies and long-term care facilities. Iowa collaborative drug therapy management arrangements allow an authorized pharmacist to initiate or change therapy, order labs, monitor vital signs through a community practice protocol, or when a pharmacist and therapeutic committee gives approval to an authorized pharmacist through a hospital practice protocol. Ohio pharmacists can set up consult agreements to issue a prescription for medications or act as an agent of the provider in the case of non-controlled dangerous drugs. As you may have caught on, there are multiple names for the same type of contracts between pharmacists and physicians, but they all have pretty similar authorities given to the pharmacist. Some other recent states that expanded direct prescribing authority: Arkansas, they can treat health conditions that can be screened utilizing CLIA waive tests. Colorado can prescribe drugs for conditions that have a test used to guide diagnosis or clinical decision making and is CLIA waived. Delaware can order, test, screen, and treat health conditions like flu, strep, COVID, lice, certain skin conditions, and other existing or emerging public health threats when identified and permitted. And then Kansas can initiate treatment for flu, strep, and UTI. New in 2023, HIV PrEP and PEP prescribing authority for Arkansas authorizes pharmacists to initiate therapy and administer or dispense HIV PrEP and PEP. Connecticut authorizes pharmacists to order and administer HIV-related tests for individuals 18 and older or 12 to 17 with the legal guardian's approval. And if the test is negative, to prescribe and dispense any HIV-related prophylaxis. Illinois authorizes pharmacists to provide patients with PrEP and PEP via a standing order by the State Department of Public Health. Rhode Island authorizes pharmacists to order laboratory tests for HIV infection as necessary and to prescribe, dispense, and administer HIV PrEP and PEP drugs according to a standing order, CPA, or protocols developed by the board. Several states allow pharmacists to prescribe hormonal contraceptives, including Connecticut, Indiana, Maine, New York, Rhode Island, and new in 2023, Vermont. Pharmacists are allowed to dispense naloxone without a prescription across all 50 states, but there is some extra authority for opioids that pharmacists have in certain states. California authorizes pharmacists, when acting under the direction of a physician or surgeon, to administer a narcotic controlled substance in the treatment of a patient with substance use disorder or addiction to a controlled substance. Maine expands pharmacists' authority to prescribe and dispense naloxone to include other opioid overdose reversing medications. Nevada authorizes pharmacists to prescribe and dispense drugs for medication-assisted treatment of opioid use disorder and perform certain assessments under certain conditions. Oklahoma expands pharmacists' authority to prescribe and dispense naloxone to prescribing and dispensing any FDA-approved opioid antagonist. And Oregon also expands pharmacists' authority to distribute and administer naloxone, as well as distributing and administering short-acting opioid antagonists. Let's start the external look at pharmacists in primary care nearby in Canada. The Canadian Pharmacists Association hosted its first summit on the future of primary care in June 2024. They released a statement summarizing their vision. Together, our vision is a system where pharmacy is recognized as a first stop in the primary care journey for all peoples in Canada. That's a bold vision for pharmacy. I'm not sure I agree with pharmacies always being the first stop for primary care, but there is some evidence out there to support it, as we've seen throughout the previous sessions. Most patients have a pharmacy nearby, and it's more accessible than a primary care physician. There's an underutilization of pharmacist expertise in the community setting. A significant number of primary care, amount of primary care involves routine maintenance of medications and vaccines, where pharmacists are already the experts. Pharmacists often produce better outcomes while being cheaper in multiple chronic conditions like hypertension, diabetes, hyperlipidemia. And pharmacists can handle minor illnesses and point of care testing at the same quality, but cheaper than emergency departments, urgent care, or even primary care physicians. Millions of patients, in this case 6.5 million for Canada, don't have access to a physician or nurse practitioner at all. So the Canadian Pharmacists Association is getting innovative by saying pharmacists may be the only option for those patients. Does that make pharmacists the first stop for primary care, or is it supplements to primary care for patients that have difficulty reaching a primary care physician? I think it's semantics at this point, but physicians may disagree here. Some other large countries that allow pharmacists to offer chronic care management are Canada, the European Union, the United Kingdom, and Australia. Some other large countries that allow pharmacists to treat minor illnesses are Canada, European Union, and the United Kingdom. And the United Kingdom has a recent expansion where they expanded pharmacist scope to include treatment for sinusitis, sore throat, middle ear infections, insect bites, impetigo, shingles, and uncomplicated UTI. This session covered pharmacist scope of practice. We dove into collaborative practice agreements, direct prescribing authority across several states, and how some other large countries utilize their pharmacists for primary care.